everyone. My name is Mohammed Ranavaya, and I'm the Associate Dean for the Continuous Medical Education for Marshall Health Network and Marshall University School of Medicine. It is a great pleasure for us to present this series of CME on demand. And today we have an excellent speaker, Dr. Hoyt Burdick, who is going to talk about physician burnout, resilience. And Dr. Burdick has been a physician for over 3 decades. He currently serves as the Chief Medical Officer for Marshall Health Network, where he oversees performance improvement, patient safety, infection prevention, regulatory compliance, and medical staff integration. Mountain Health Network is a 4-hospital system affiliated with Marshall University and Jones C. Edwards School of Medicine in Huntington, West Virginia. Dr. Burdick graduated from University of Mississippi School of Medicine, where he completed his training in internal medicine as well as the pulmonary diseases and critical care. He has served in numerous leadership positions, including state and national roles as trustee on the board of American Association for Physician Leadership, as chair of the Physician Executives Forum of the American College of Healthcare Executive, as well as in several leadership positions as a delegate to the American Medical Association from West Virginia Medical Society. I have known Dr. Burdick for a very long time. He's a colleague, a mentor, and a great supporter of our CME activity. He believes in lifelong learning and has been a member of the Marshall University Graduate Medical Education Committee and also serves a very critical role on our Continuing Medical Education Committee for many years. He will join us today and share with us an update on the timely topic of physician burnout, well-being, and resilience. This activity has been approved as an enduring CME activity for 1 hour of AMA PRA Category 1 credit by Marshall University School of Medicine, which is accredited by the Accreditation Council on Continuous Medical Education, ACCME. The disclosure of conflict of interest is available not only on file, but also is part of this presentation. So without further ado, I will invite Dr. Hoyt Burdick to share with us what he has over the years talked about physician burnout, well-being, and resilience. Dr. Burdick?
Thank you, Dr. Ranavaya, for that gracious introduction. I'm so excited to be here today to share with you some of the things I've learned about physician burnout, well-being, and resilience. I've had a growing interest. It really became frontline press during the COVID era, which I guess we're still in, maybe not the pandemic era, but I just had questions. Is it real? Is it something new? Can you measure it? What are the causes? What can you do about it? And how can we help ourselves? The purpose of this educational session is to provide physicians with knowledge on recognizing burnout, understanding its causes, and implementing strategies for personal resilience, self-care, and mental health support. Hopefully this will improve physician performance and patient outcomes. There are 5 learning objectives, and it starts with recognizing the personal and professional impact of burnout on care, quality, patient satisfaction, relationships, and physician well-being. Burnout is real. I discovered this small community in North Alabama after driving down to visit family, and was thinking about this presentation and whether burnout was real or not. And there is a Burnout Missionary Baptist Church in North Alabama, complete with a burnout cemetery, but it's more than just a place in North Alabama. This review article from the New England Journal by Gill and Sen a brief history of the construct of burnout. The construct of burnout goes back to the 1970s. Two psychologists, Freudenberger and Maslow, first described burnout and people helping professions who became emotionally drained over time, which led to detachment and negative feelings toward the people they were trying to help. Physicians often enter medicine with the same goals and find that excessive workload, administrative burdens, and profit motives of insurance and pharmaceutical companies are intractable barriers to improving patients' lives. And it's not exactly what you envisioned when you signed up for med school. Maslow developed a test, the Maslow Burnout Inventory, MBI, and it was developed to bring some metric to the construct of burnout. It is the most widely used construct, and it measures burnout in three distinct components: emotional exhaustion, depersonalization, and a depleted sense of personal accomplishment. Statistics show with this index that approximately 50% of U.S. physicians meet criteria for burnout. The literature on burnout identified 142 different definitions, although most use the Maslow Burnout Inventory for measurement. Medscape does an annual physician burnout and depression report. This is from 2024. I'll tell you a little bit more about the survey. The methodologies, it's a 9 or 10-minute online survey. They were all required to be U.S. practicing physicians. There were almost 10,000 respondents across 29 plus specialties, and this was July 5th or October 9th, October 23. And it was the data was weighted to the AMA membership by specialty and state, so it would give a better representation of subspecialties. And we'll see what the survey says. The first survey question was, which physician specialties are reporting more burnout? What would be your guess? Mine was primary care. Turns out they're all around 50%, so there's not a big difference, but the red line is those above and below 50%. And what you see above the line, emergency medicine, of course, in 23, we were still on the tail of the COVID pandemic. And you see a lot of primary care, along with radiology, anesthesiology, but internal medicine, family, peds, OBGYN are all above the line of 50%. The below the line with lower burnout rates are some of the more procedural areas, critical care, surgery, orthopedics, ENT, and it appears that the least burnout are plastic surgeons and ophthalmologists who restore vision and beauty. So their rewards must serve some protection against burnout. Next question, do more male or female physicians report burnout? I would have guessed male, and I would have been wrong. This is the trend over time since 2018, and that gap of about 10% persists for males and females in the burnout index. You will see some interesting rise from 21 through 23 with the COVID pandemic, and a fall off or decline in 2024, which we'll talk a little bit more about. The next question is, what contributes most to physician burnout? These are some quotes, and they all focus around job stress. Takes 12 hours a day at work just to keep my head above water, plus working 3 to 4 hours each day on weekends. The bottom one probably would score high on the burnout inventory. I've reached my limit for the BS I can take from the hospital administration, insurance companies, and demanding patients. So it goes from, gee, I'm tired, to I can't take this anymore. So which work activities, are more likely to lead to burnout? In the survey, at the top of the list, 62% said too many bureaucratic tasks, not enough patient contacts, too many hours at work, lack of respect, and interesting, insufficient compensation, because we'll come back to that. You would expect lack of control, autonomy to be frustrating. EHR, I would have thought might have been at the top, but it's kind of tied to the bureaucratic task and insufficient lack of control and autonomy, government regulations and other. Next question in the survey was, what have physicians changed in their practice to reduce burnout? So what can you do about it? Physicians in the survey had reduced work hours, about a third of them. A fourth of them had changed work settings or got a different job, making workflow or staff changes to ease their own workload, and speaking out with hospital group administration about productivity pressures. 4% just sold their practice and put it up for sale. What workplace changes might be most helpful? Here's how they change their work environment, but the question would ask, what would you change? There it is again, increased compensation. So nowhere in the burnout inventory is poverty or insufficient compensation, but that's how the questions were answered in 24. Adding support staff would make sense, making the work schedules more flexible, which would give increased physician control and autonomy. So you're starting to see a theme of being able to control the practice, more respect from administrators, employers, colleagues, and staff, a lighter patient load, making counseling available or checking in with physicians, only 9% indicated. So there's increased compensation. So money, I don't think is the answer to burnout, but that's how it came out on the survey. Is workplace burnout affecting personal relationships? Well, obviously, yes. There's 86%, yes, a lot, yes, somewhat, and only 14%. So it's not just about work. It also impacts personal relationships. So how are physicians coping with burnout? In the survey, physicians said, started out pretty good with exercise, talking, sleep, spending time alone, listening to music, and then it kind of digresses to junk food, alcohol, binge eating, prescription drugs, nicotine, cannabis, none of which we would recommend, but I admire the physicians for honesty. I just worry a little bit about that 2 or 3% who have unhealthy means for coping mechanisms for burnout. So why not seek professional help? And that answer for physicians, you and I know, is multiple reasons. But 53% said no, they haven't, and they didn't in the past, and 8% said they were afraid to answer. So that speaks volumes. So why not? There's a stigma associated with the concept of burnout, that it's somehow it's a personal failure rather than a consequence of the environment. And we consider depression to be a weakness that makes a negative statement. 40% thought it made a negative statement about them. They were afraid people would think less of them or doubt their abilities, or it could somehow affect their licensure board or employer. So how 5 insights into combating physician burnout. This is fast forward a year, 2025 Medscape, same type of survey, different picture. Here is 3 physicians enjoying some Starbucks and meditating, and they reframed the questions. So instead of asking them about their happiness and burnout, they ask, is it attainable in my profession? So 3 out of 4 said, yeah, it's happiness and joy and practice and balance are achievable in my profession. And it was same for early, you think it might be a phenomenon more of early, mid, or late, but it was the same kind of response that yes, it's possible across the early and late career physicians. And still, as we saw in the graph from 24, about half of physicians grapple with burnout and/or depression. So this is the inverse of the previous Medscape survey, and it's about possibilities. Can doctors in your specialty be happy and balanced? And there's dermatology and ophthalmology. I don't know where plastics is still strong. Um, and the specialists who thought not quite as much, still 2/3. Emergency medicine, which was the most burned out, also saw the least potential for joy in practice. This is interesting. In the 24 survey, um, it was all about money. Money was the answer. In this survey, respondents were asked if they would accept a reduction in salary compensation for a better work-life balance and more free time. And it was 2 to 1. Yes, I would take a pay cut, which kind of runs counter to the previous year's survey. What would they do with that time? Well, most doctors covet more personal time and family time right now. 3/4 thought that was very important. So that awareness that it's affecting personal relationships starts to come through in this survey. Um, Vacations, 70% say it's very important. Doing something besides practicing medicine, 58% more important. So the emphasis on getting a life, somehow managing the stresses of work and still managing to have a life outside of practice. This was a great review article in New England Journal of Medicine, 2024, and there were 5 key steps in improving well-being and reducing burnout. And they go along with what the survey said: reductions in workload, support for mental health evaluation and treatment, although very few physicians are willing to avail themselves of it. Use of valid assessments of burnout, which we talked about, the Maslow burnout inventory, determines what works. So we still don't know exactly what works. We know it's not binge eating or cannabis or nicotine or alcohol. But what are the effective strategies that work? And if you know the strategies, what can you do to target those interventions? This article talked about what the healthcare systems or organization can do to address burnout and improve well-being, and what really requires more research. So a consensus on definition, which we've sort of found with Maslow, valid measures, interventions that have demonstrated benefits. So true research on, did that make a difference? Did a better EHR make a difference? Did a better schedule make a difference? And how did you accomplish that and maintain productivity? This is a summary from the Medical Group Strategy Council Advisory Board, and this is more from a healthcare executive standpoint on 5 insights to help combat physician burnout. This is the best visual definition of burnout I found in my research. There are 3 components that intersect in this Venn diagram. It starts with, as it did with the quotes, dissatisfaction. I don't like this. It progresses to not only I don't like it, I don't even want to do this anymore, to burnout, which is, yeah, I just can't do it anymore. The BS is too much to handle. So there are kind of 3 degrees of depression, starting with dissatisfaction, disengagement, and then actual what we classify as burnout. The advisory board said burnout has very real consequences, not just for individuals, but for organizations. And those 5 elements: apathy toward work and colleagues, more importantly, indifference to patients, feeling overwhelmed and frustrated, increased mental health concerns, but just a loss of joy in the practice of medicine. The reason you went into medicine, it just doesn't resonate as much. Besides those personal consequences, there are business consequences of burnout. Um, there are studies showing patient experience. How you score in the burnout scale affects the patient experience. 16% decrease in patient satisfaction when you have a high burnout score, 11% increase in medical errors and burned out surgeons. And recruitment and retention, turnover. Younger physicians are leaving medicine or retiring early, and increased, not if the burned out physician may stay, but everybody else leaves. Increased turnover in clinical and non-clinical staff because it's no fun. Again, what can you do about it? With organizational strategies from the advisory board had 5 elements which align with what we previously heard. First, recognize it might not be who you think. You can't do a MAS-like burnout inventory on every physician and will put on a happy face and appear stoic and are really struggling. So being sensitive to recognize it might not be who you think, being prepared to listen, and creating a safe space where someone feels free to talk. Giving physicians some autonomy. If there's choices in operational initiatives, explain them, engage with physicians, give some autonomy, sense of control back to physicians. Even the score, don't just complain to the physicians about symptoms of burnout, but give them the positive feedback for the things that they are continuing to do well. And just being there as another human being. So this is the advice from advisory board, from healthcare executives on how organizational strategies to improve burnout. Most important thing should be coming through by now is just stop doing stupid things. Change the system so that there are fewer stupid things to occupy your time. And that comes to, this is one of my favorite articles by Sinsky and Panzer in the New England Journal. And it's a short article, and it's all summarized in a couple of diagrams. There are 2 types of physician work: the solution shop and the production line. We'll start with the production line. That's just the stuff you got. There's a lot of stupid stuff on the production line side, signatures and papers and inboxes and phone calls. And it's not really how we envision the practice of medicine to be. RNs have a big role there on the production line side, and medical assistants do. And most of the QI efforts, when you try to improve efficiency, are on the production line side, not true practice patient care related efficiencies. The solution shop work is where we should spend, a proposed model, it's where physicians should spend more of their time. And those QI efforts should cross that line, not just to be on the production line side, but on the solution side. RNs can do more than we allow them to do within their licensure, and they can move some of that production back to the production line work, back to the MA. So it's an upshift from the MA to the RN to the physician, and the QI efforts to change the system to make that work. So this is what solution shop work feels like. It's thoroughbred racing. It's what we went to med school for. It's the excitement, the joy, the intellectual challenge, the emotional reward of practicing medicine while everyone cheers. And this is what it feels like for production shop work. So for me, in this research on burnout, that very short article on solution shop versus production shop, and the solution to burnout is to have a little less production shop and more solution shop work. This is Dr. Lorna Breen. She was the New York Presbyterian ER director, and And in that advisory board, she went from, I don't like this, to I don't want to do this, to I just can't do it anymore. She was, New York Presbyterian was hard hit by COVID in 2020, and she was the ER director, and she contracted COVID and was quarantined at home, did not require hospitalization, was back in Charlottesville, her hometown, on a break, and just could not fathom going back, and took her own life. Her father said she was unflappable until she faced a new enemy, and she was as much a victim of COVID as the patient she was treating. Um, it did, however, result in some public awareness of the healthcare provider impact of burnout. Um, and this public law passed in 2022, bipartisan, established grants for training health profession students, residents, healthcare professionals in evidence-informed strategies, prevent suicide, burnout, mental health conditions, substance use disorders, all those things associated with burnout. So it seeks to identify and disseminate evidence-based practices. We saw in the New England Journal article that we need scientific evidence-based practices for reducing burnout. Um, National evidence-based education and awareness, which I'd like to think this CME event is a little bit of that, although it's not sponsored by the Lorna Breen Healthcare Provider Act, and a comprehensive study on healthcare professional mental and behavioral health, including burnout, as well as in 22, what's the impact of the COVID pandemic? And it comes back to solution production work versus solution shop, and that drives job satisfaction. Back to this review article, which we've already talked about. If you're going to research, we talked about the 4, 5 areas of research: consensus definition, valid measures, effective implementation strategies, evaluation of those strategies, and identifying factors driving poor well-being in women and underrepresented groups. So this is Vivek Murthy. He was the Surgeon General of the United States. And he asked a question: will we step up and meet our moral obligation to care for those who have cared for us? He had a publication addressing health worker burnout, which included physicians. Again, you see in the quotations, I can't provide the best care for my patients. And the patient saying, I can't get the care I need. For every hour of direct patient care, physicians currently spend 2 hours in the EHR. So there is still opportunity and efficiencies. We need to keep working with our IT compatriots and physician informaticists to be able to spend less time in the record and more time with the patient. And it's bad enough for physicians, but nurses at the bedside spend 41% of their time in EHR and documentation. The factors in the Surgeon General's report associated with burnout among health workers are societal and cultural. Health misinformation is a big stressor. Mental health stigma we talked about, and the system itself contributes to burnout by misaligned reimbursement policies, administrative paperwork, doing stupid stuff, inefficiency, poor coordination. Organizationally, there's often a lack of leadership support, excessive workload and work hours that are unreasonable expectations, and the workplace and learning environment, limited flexibility, autonomy, and voice, which we saw. That type of environment leads a human being to just become frustrated with the system and withdraw. So Dr. Murthy said we need to thrive together for solutions that to health worker burnout, and shift from a problem with the person to a problem with the system, from a me problem to a we problem. And it's all about trust and culture. And the roots or the uh, sources of this trust: federal, state, local government, healthcare organization, insurance payers, family members, friends, licensed accrediting boards, and of course, researchers, which we emphasize. Um, a sense of connection, restoring that sense of connection. We talked about the original definition of burnout being among social workers who became disconnected from the people they were trying to assist. And trust brings back that culture of healing, community, belonging, and connection. Here's a quote from Vivek Murthy from that New England Journal Perspective article in 22, where he talked about more than half of healthcare workers, which we've seen that trend, which didn't start with COVID, it just got worse. He proposes addressing healthcare worker well-being by valuing and protecting health workers, uh, living wage, PPE. This was during the COVID peak, workplace violence. But here we are reducing administrative burdens, the stupid stuff we do with prior authorization, the stupid stuff we do with streamline paperwork and get rid of stupid stuff. Gross. Um, Increasing mental health care for workers, if workers will avail themselves of it. Parity in access for payment for counseling or mental health. Strengthening public health with an emphasis on social determinants of health. And here's back to that tree, that culture that supports well-being, breaking the silence, reestablishing connection, education. And Dr. Murthy says a rising generation of healthcare workers need to advocate, healthcare workers themselves need to advocate for policies and organizational change. No one's going to do it for us. AMA has been instrumental with their program Steps Forward, um, and their emphasis on the foundation for joy in medicine. And it states that organizational changes can improve burnout, can lead to physician satisfaction. Here are the various dimensions of drivers, and it's the same thing. In the center is finding that purpose and meaning, joy in medicine. Burnout leads to exhaustion, cynicism, and inefficiency, which we've discussed. Engage on the other side, the more optimal, improved engagement, vigor, dedication, and absorption in the practice of medicine. And again, this is not a me problem, it's a we problem. It's a system, organizational, an administrative thing. Uh, we talked about efficiency, workloads, autonomy, uh, having a life outside of work, social community support, and organizational culture and values. In their steps forward, there were 9 steps to creating organizational foundation for joy in medicine. There were the professional fulfillment is the standard in the center. This is the Stanford WellMD model, and there are 3 components: personal resilience, which is not the problem. It's can be diminished by the environment, but it's not so much a personal failure, but it is a task on if there's not a culture of wellness and there's inefficiency of practice, personal resilience diminishes. This is a busy slide, but it reiterates what we saw in the other slides in research. Engaging senior leadership in the work environment, tracking the business case for well-being. We saw more efficiency, fewer errors, greater patient satisfaction, um, resource wellness infrastructure. And that's more difficult than it sounds, because we really don't know exactly what works other than improving autonomy and efficiency. measuring wellness and predictors of burnout longitudinally, strengthening local leadership, and develop and evaluate intervention. So here we are back on this where we started, on the same page with we need more information about what's out there, what can be done, and what works. Um, Step 7 is the workflow efficiency and power of team-based care, delegating some of the it's not stupid stuff. It feels stupid. It's necessary stuff. So I say that not lightly because someone's got to do it. But if it can be delegated, it can improve the efficiency and reduce burnout and reducing the clerical burden. And they say taming the EHR. Um, and of course, the personal resilience, that's those individual skills, behaviors, and attitudes that contribute to personal, physical, emotional, and social well-being. This is some screenshots from a webinar I saw from the AMA Steps Forward on peer support. So this is about helping each other, not depending on administration or the counselor, but really physicians helping physicians. This is Angela Chowdhury. Dr. Chowdhury is chief of GYN at Northwestern. She talks about the personal side, and we saw that in the survey that it affects broken relationships, alcohol, substance abuse, depression, suicide are on the negative side of personal impact of burnout. On the professional side, we saw there was decreased quality of care that's measurable, increased medical errors that's measurable, decreased patient satisfaction that's measurable, and productivity and physician turnover or staff turnover. So this was the interesting, Dr. Chowdhury said this is not the answer. It's not free food in the doctor's lounge, muffins, resiliency workshop, as though there's something wrong with the person, nap time, yoga, meditation, those things, she very wisely points out, might be an initial approach toward burnout, but they're all misdirected. The key takeaways from her presentation is that culture of wellness is built by collaboration between the organization and its people. And it's got to include caring for the individual, enhancing the workplace, and building community, that sense of connection that can be missing when you're under the stress of burnout. And most importantly, peer support is critical. If you're going to achieve those three things of caring for the individual, enhancing the workplace, and building community, we have to help each other through emotional support, coaching, or mentorship. And the keys to a successful peer support program were leadership and training on how to do it, sense of confidentiality and trust. We talked a lot about practicing physicians and burnout, depression, suicide. It is not only the practicing physicians who are subject to this stresses that lead to burnout, but residents and fellows are particularly new to that stress. And we find burnout rates equal to or slightly greater in residency and fellowship. So it starts very early in our profession because the environment is already there. So it's not something you start out optimistic and bright-eyed and end up burned out. It is a human response to overwhelming stress and circumstances beyond your control. And if you recall, it was just started our new residence in July, and I remember very vividly that first day on the wards as a real physician. But AMA has Steps Forward program, Joy in Medicine, focused on residents and fellows to optimize well-being at work for physician leaders. And here are some of the differences, some of the similarities you'll see also, but in stress factors between residents and practicing physician. And you will remember these. you have even less control and autonomy over your work hours, workload, and schedule. The AAMC is put some duty hours in place since many of us trained. But even with that, there's not much control or autonomy over those work hours and workload and schedule. There's even less time as a resident for healthy lifestyle habits, exercise, adequate sleep, those things we saw that improve resilience. And there's that need to balance doing it yourself and getting help, clinical autonomy versus necessary supervision, which is very stressful. There's a need to balance studying and doing, balance education, book learning, online learning, excuse me, I don't use books anymore, and service, learning procedural skills and hands-on practice of medicine. Again, the personal life changes from graduating college to entering med school to becoming a resident. There's often relocation, separation from all the common things that you share, potential social isolation, uncertainty about where you're going to practice or whether you're going to pass your boards. There's that obvious adjustment to a new professional role as a practicing physician, as a doctor, while developing competence. And there's that hierarchical structure of academia, which may work well for training, but it can lead to feelings of powerlessness. There's potential mistreatment in the hierarchy. There's judgment if you advocate for your own needs, as opposed to speaking up and saying, I need help, or simply not knowing what to ask for. And with the med school debt hanging over your head and the salaries, entry-level salaries and benefits of residents and fellows, there's a higher degree of financial stress. So burnout starts early in the medical career. It's not confined to practicing physicians. And the AMA has recognized that there are differences in stress factors, but it's just as important that we look at the same principles for preventing and addressing burnout and the joy of medicine for residents and practicing physicians. So we talked about burnout and represented as a loss of compassion. And you would think, I've heard the term compassion fatigue. This book by Trzeziak and Mazzarelli, Compassionomics, is full of research on metrics on the impact of scientific evidence that caring, more compassion makes a difference. Don Berwick, one of my heroes from the IHI and was head of CMS for a while, said Compassionomics provides the evidence that one simple tool, compassion, can affect not only the outcomes for our patients, but also the financial well-being of organizations and the well-being of providers. And what exactly is compassion? Well, it's not just feeling sorry for someone, that's empathy. It's empathy combined with the motivation to do something to help. And that's what is drained in burnout. But compassion surprisingly restores that sense of joy in medicine. This is a book from two ophthalmology perspective. It's a review of the book. If you don't want to buy the book, this article, which is referenced here, is in a few pages, the entire book. And of course, there are ophthalmologists who are very happy and less burnout to start with. But they reviewed this book and said compassion is the emotional response to another pain and suffering. Not just emotional response, which is empathy, accompanied by a desire to alleviate it. And there are there's a way to measure compassion, which they go into in the book, but the physicians with greater compassion improve physical and psychological outcomes, increases compliance, patient adherence. If you're compassionate and they feel you really care about them and you're trying to help them, their willingness to follow through with healthcare recommendations, medication compliance, improves healthcare quality and safety, which we've seen, increases financial margins, and they come forward and say it prevents physician burnout. So you would think too much compassion leads to burnout, compassion fatigue, but this is just the inverse. So here's some quotes from advisory board. The practice of medicine is tough, but it comes with a considerable bounty of rewards. After all, despite the rise of physician burnout, physicians we spoke with emphasize how much they believe it is a privilege to be in the art and business of healthcare, practice of medicine. I couldn't imagine doing anything else. Dr. Martin Young said, "For this is neither an easy nor a comfortable job, but the rewards are every now and then overwhelming, amazing, euphoric." And that's the solution shop picture of what it's like to practice medicine. Here's a great philosopher from Nashville, Luke Combs, in the lyrics of his song. Someone asked me once in an interview what was growing up like, where'd you go to school? And what would you do if you weren't doing this? And he goes on to talk about his life in country music, and he would be doing it anyway. Another philosopher from Nashville, um, Tim McGraw, says, when the dreams you're dreaming come to you, when the work you put in is realized, let yourself feel pride, but always stay humble and kind. So burnout is not just a place in North Alabama, and hope is not just a place in Arkansas. I hope we've covered these learning objectives, recognizing the impact of burnout on care, quality, satisfaction, relationship, physician well-being, looking at some of the strategies to combat burnout, advocating ourselves for systemic changes that will make a difference, learning personal resilience techniques that will strengthen our personal resilience in spite of the burnout factors, and understanding the systemic factors that healthcare contribute to burnout, such as administrative burdens, workload, and poor work-life integration. That concludes my presentation. I've had a blast preparing for this, and I hope you enjoy the CME event. Back to you, Dr.
Thank
Ronavai.
you. Thank you, Dr. Burdick, for a very informative presentation. On a personal note, Hoyt, I can tell you I'd been riveted in listening to this. And I can tell you, the 3 decades that I've known you, you have lived it. I can personally vouch for it, that you lived to be humble and kind. So thank you for that. On a personal note, I have few
Thank you.
questions, which I think would be appropriate for us to discuss before we close this session. So you mentioned in your presentation that physician responded that counseling, only 99% physicians responded to counseling was appropriate. Why is that? Is it because some of us feel that we are doctors, we don't need any counseling, or because we think it's a sign of weakness?
You're absolutely right on those 2 points. There's such a it requires it. I think the rigors of medical school require you to become a Superman, Superwoman. We see struggling emotionally with the academic, first of all, the academic burden, but then the clinical burden as a sign of weakness. And with the stigma that comes along with that, rather than realize we're human. And when you're faced with insurmountable daily grinds of things you seemingly can't fix, you become like the plow horse rather than the race horse. But you won't see the horse, you won't see the veterinarian to get things fixed. I hope that analogy rings true.
It does. Thank you. I'm curious, and I think our audience are curious too, because this is such a timely topic, but rarely spoken. Dr. Burdick, what sparked your interest in the subject of physician burnout, and to share what you learned?
Oh my. Well, first of all, I was offended by the term. It sounds like there's something wrong with the physician, or that there's only so many on the opening slide, so many match heads that you have, and you're burnt out and you're done. That made me angry. Um, that's not what burnout is about, and it was being mischaracterized just by the term, even though it's been there since the 70s. So I took a deeper look, and also I've got the best job in the world. I'm the chief medical officer, and I get to work for patients, but with amazing physicians. And there are times when physicians experience lack of behavior, lack of professionalism. It gets the best of all of us sometimes, and sometimes it's a pattern. And as I see that, it breaks my heart to see well-trained colleagues who admire acting out in ways that are uncharacteristic. So to be more effective as a chief medical officer, I've sought to kind of learn from them, listen to what, and there's never quite a justification, but there's always a good reason behind being becoming unprofessional. But that was the other was from a purely personal interest. How can you help someone who feels overwhelmed and desperate?
So it comes back to being humble and kind and supportive.
Tim McGraw was right. It applies to everyone.
So my thought is that burnout, we heard a lot about it during COVID era, and it became a real buzzword. And maybe COVID just highlighted what was the underlying problem coming up in the past decade or so with all the changes in the healthcare. And as the healthcare dollars started shrinking and stresses started to rise across the entire healthcare spectrum. So the question I have is it a real phenomenon continuing on, or what do you see in the future?
I'd say absolutely it is. In the COVID era, it was interesting. It was the focus initially on burnout was nursing. If you remember, compassion fatigue, people with N95 face ulcers from hours and hours, like uh, Lena in New York Presbyterian Hospital. Um, uh, so it is very real among physicians, and I think the administrative burdens. I believe we're seeing a shift. I know we're seeing a shift in employment. Um, and, Physicians may choose to be employed for good reason, for burnout, for better solutions, but that loss of autonomy um, in from independent practice, and now beyond employment by health systems or hospitals, private equity is putting a huge burden. They pay a great price, buy in, and then they squeeze the dollars out of the system and the efficiency out of the racehorses. Um, and I believe those pressures um, are contributing. It's not all doom and gloom though. Uh, Artificial intelligence, augmented intelligence. Just this morning, right before um, we went live, there's an article in Becker's about ambient digital scribes and how much they help. But in 44 patients, there were 127 errors. 70% of the charts had at least one error. The shorter version left out omissions. The longer versions had more irrelevant note bloat and actually invented some discussions that did not occur. So it's not, it doesn't mean you you can stop being a doctor because the scribe is scribing it all. It still requires editing, but if you can do it more efficiently, if you can save 2 hours a day, that's 1 hour to see more patients and getting home an hour earlier in the evening.
So you talked about, and I think this is what you just alluded to in your last comment. In your presentation, you talked about an acronym GROSS. I was fascinated by this: get rid of stupid stuff. What is being done nationally, and what is being done at our institution? You as a CMO will have a ear to the ground. I'd like to know, and I'd like our colleagues to know, what your thoughts are as a thought leader in the industry, uh, that is being done and what needs to be done and what should be done to get rid of stupid stuff.
Oh my. Well, I think a good starting place is just Googling AMA steps forward, joy in medicine. I have several slides in my deck from that process. They actually have grants. I don't know if it's the Lorna Breen dollars or if it's AMA dollars for institutions to implement programs. Um, there's a John Sawyer is a neuropsychologist at Ochsner, who is working, helping remove administrative burdens, providing real world solutions. He's got pharmacy and IT rolling out major initiatives to improve practice efficiency and decrease work. This came in just minutes before the presentation. So there are institutions that are recognized by the AMA with grants. They're called Joy in Medicine grants. Just like that production shop solutions shop, they're using performance improvement, quality improvement initiatives to shift the doctor's work more over to being a physician and less into being an administrative clerk.
Yeah, you already have alluded to, but I have my final question, which is the uh, comments I've heard from colleagues, from graduate students, doctors, residents, about the slave they feel to EHR, or electronic health record. And you mentioned that also. So, what is being done concretely that reduces the burden, and what more can be done that would reduce the burden and hopefully reduce also the burnout?
Wow. Well, there's a lot that is technology driven, um, improved efficiency. Oracle is really trying to get Cerner to be more usable. I can just, it's not a product endorsement. I don't get any money
Yeah,
from Oracle for saying that.
I understand that.
But it
My
just happens
question
to be,
was,
it could be Epic, which is also involved in a
sure,
major process of. One of the things that the medical staff did for over 6 months before go live March 1st at St. Mary's um, is look at the existing workflow order sets, the way the medical record works. So there are things you can change and improve as far as alerts and uh, inbox management and prioritization. So I'm looking to the new generation of students and residents and folks coming behind us to continue that path of make the record work for you, for the clinician, for the way we think, the way we work, make it fit the workflow rather than changing the workflow to fit the EHR.
thank you very much, Dr. Burdick, for a very informative presentation. Once again, we're grateful for your participation. And now for our audience who are going to be receiving the credit from the CME on demand, as I previous program completely, your feedback is essential for assessing the effectiveness of this activity and for improving future educational program. Physicians should only claim credit commensurate with the extent of their participation in this activity. This content has been developed in compliance with the ACCME's standard for integrity and independence in accredited continuing education, ensuring that it is free from commercial bias. There is going to be a QR code at the end of this presentation or a link, whichever you prefer. Please communicate through that to us and your feedback on the program, at the end of which you will receive your credit. Once again, thank you all for your participation.